A very good morning from RSSDI Chennai. I'd be talking about the errors in the management of type 2 diabetes. So as you can hear, like we all are aware of what has gone wrong when we treat diabetes. It could be a patient's perspective. Sometimes we do hear we couldn't exercise or we are fine. We just checked our blood glucose. So there are very many issues or I should say certain dictums we follow once we talk about a management of diabetes on a day-to-day basis. We don't check regularly, we don't walk regularly, we don't actually talk about the complications as per se. So these are the patient's perspective, but today I would be talking more on the errors in the management of diabetes, what the diagnosis, the classification or the prescribing errors and the medical errors in toto. So firstly, the diagnostic errors. The three modalities which we all are aware are the fasting blood glucose, the 2-hour postprandial blood glucose and the A1C level. So this is all which are being always prescribed by a doctor. But do you really know this fasting needs you to be 8 hours fasting? The sample what we collect is the venous plasma sample, and the plasma, the sera needs to be tested, and so the testing should be done within hours of collection of the sample so as to get the best of the results. Similarly, the A1C should be done from the standardized laboratories, and there are so many hemoglobinopathies, the pregnancy, the various certain liver conditions where A1C should not be solely used as the diagnostic criteria for diabetes. So once we have a confounding factors, like 2 of the diagnostic criteria are suggesting the impaired glucose tolerance and one may not be suggestive. So oral glucose tolerance test or a postprandial should be a better methodology, though nothing seems easy, needs preparation, needs time. So these are one of the errors which could be there if you don't give time to the patient to explain the procedures and the diagnostic dilemma. And even single test may not be diagnostic. Single capillary blood glucose is non-diagnostic. It needs a repetition of the either of the sample, preferably laboratory report of the venous sample. Coming to the classification, there is, as the standards of medical care, the type 1 diabetes, type 2 diabetes, other form of diabetes and GDM. This has been the conventional classification, so on. Now WHO has come with the 6th classification, or based on the management principle, we have a cluster dependent classification where we talk about type 1 patient or a lean type 2 diabetes. Yeah, it again is a confusion. Talking about MODY and type 1, another confusion. Talking about fibrocalciptic pancreatic disease and type 1, another confusion. The diagnostic test of the autoimmune markers are expensive. The presentation may vary. It can be a ketosis prone type 2 or a type 1 patient not showing features of autoimmunity. It can be a LADA, which is now known as slowly autoimmune mediated diabetes. So yet an exhaustive workup which may lead to a diagnosis of diabetes is mandatory, and this could create errors in the management of diabetes. Coming to the common errors which we're talking about, the medical errors. So we always talk about omissions and there are certain lapses and slips which may occur, or commission. We all agree we have to reduce certain omissions in our prescriptions where with which our the errors would be reduced. The education holds a key point when we want to talk about reducing the errors in the prescription, reducing the errors in the management of type 2 diabetes. Prescription should be complete. It should have the diagnosis of type of diabetes, the duration of diabetes, what are the complications which the patient presented, what was the previous history, what was the previous status which are missed. The anthropometry is missed in a routine day-to-day practice with the busy practitioners. How many patients actually we had a regular examination of weight, height, waist hip ratio, waist circumference. This needs to be pondered. Also, not only the anthropometric, we need to have a monitoring, the monitoring like fasting blood glucose or the random blood glucose at every visit, blood pressure at every visit, checking of or the monitoring of the lipid profile every 6 monthly or a year, fundus examination 6 monthly to a year, the dentist checkup around a year, the foot examination every visit. So there should be the guidelines, or there are the guidelines which determine what and how the complication needs to be monitored. These, and noting it down in our prescription or using a computerized method of giving a prescription may definitely reduce the errors in prescribing. Not only this, the medication errors. Whenever you are prescribing an anti-diabetic to your patient, you have to know the duration of diabetes, the complication patient may be suffering. He may have a EGFR less than 60 or a EGFR less than 30. Whether you want to initiate metformin, whether you want to reduce metformin, or the dose reduction, the some of the medication which may have side effects should be avoided. The dosing has to be mentioned in the prescription itself. So there are very minute and small details which should be taken care when prescribing the medications, especially in diabetes patient, looking care for the drug interaction, side effect profile, and hence we should be very particular to avoid these errors. Only one thing which remains is the education, patient education and training, so as to avoid these common errors in the management of diabetes. Thank you.